Onc Live Insights is a video editorial program produced by Onc Live.
There was a large randomized clinical trial conducted in Europe that looked at maintenance rituximab in older patients with mantle cell lymphoma, and the trial showed a large benefit, a large remission duration benefit after R-CHOP chemotherapy. And a lot of us have extrapolated that data and are now using rituximab maintenance after R-bendamustine therapy. I feel like that's a safe extrapolation. So rituximab maintenance is a commonly used strategy for older patients with mantle cell lymphoma. And there was some data presented just at the last American Society of Hematology meetings looking at rituximab maintenance after stem cell transplantation in younger patients, also showing a big progression-free survival benefit. That data is not published yet, but I think when it is, there's a strong likelihood that it'll change the standard of care and that maintenance rituximab will become routine after intensive treatment strategies. I don't think that all transplant-eligible patients have to have a stem cell transplant with mantle cell lymphoma. About 20 or 25% of patients with mantle cell lymphoma will have a more indolent version of the disease. These patients can enjoy very high quality, very durable remissions using non-intensive chemotherapy approaches. I have many patients in my practice who were treated 7, 8, 10 years ago with a frontline regimen that did not include a stem cell transplant who are still in their first remission. And so I think it's important that people remember that stem cell transplantation for mantle cell lymphoma has been shown to improve progression-free survival, but the impact on overall survival is not proven. And so if you have a patient who opts not to do an intensive therapy, who opts not to do a stem cell transplant, I think that's completely appropriate, and I think the patient should have a big vote in that decision because there is no proven impact on overall survival at this point. There are some transplant centers who feel as though a TBI-based conditioning regimen improves outcomes with stem cell transplantation and mantle cell lymphoma, but it also adds more toxicity. It increases the risk for second malignancies. And so I think that the TBI-based approaches are a reasonable alternative or a reasonable option in mantle cell lymphoma, but standard beam chemotherapy conditioning regimens I think are also just as valid as a conditioning regimen in mantle cell lymphoma, and I try not to be too dogmatic about which conditioning regimen is optimal.